It's so nice to be here with all of you today. So I'm honored to be here to speak to you about what the city of Philadelphia is doing in terms of reducing maternal mortality. The sort of mantra that we've taken and like sort of the way that we've looked, the framework we've adopted to sort of look at this problem is the term building bridges. And so peppered throughout my presentation, I'll be sort of referring to that term because that's kind of how we like approach this problem. So Merriam-Webster defines building a bridge as to establish a relationship that fosters understanding between an appreciation of cultural differences. And so that's kind of the framework we've adopted in terms of bringing people together that may not necessarily be in the same room or used to working together. So the objectives today are to really describe to you the maternal mortality program in Philadelphia and discuss our review process and our recommendation development process, and then offer the framework and sort of a look at the way that we've sort of implemented these recommendations and adopted that building bridges framework. So just, I understand this is the American College of Physicians, and so I wanted to sort of bring it back to history. So maternal mortality review in Philadelphia actually has a long history in Philadelphia. The first formal review was actually conducted in the 1920s by the Philadelphia County Medical Society, and they released their first report in 1934. And then after that, annual reviews were conducted through the Obstetrical Society of Philadelphia, and those were done probably through the 1970s based on the OB Society records. The modern DA MMR really began in 2010. It was briefly started in 2007 and then paused. And Philadelphia is actually a leader in this sense, as like developing a county level team. There are actually now 2 or 3 other county level teams that have come up in existence in the last few years, but we've been around, like I said, for about 11 years. And so for a long time, we were the only one. The team is multidisciplinary. We have people on the team that are sort of all kinds of stakeholders that may impact maternal health both during pregnancy and postpartum. So that includes clinical providers, community people from community-based organizations. We have community members on the team, doulas. We also have insurance companies represented, and so we really try to take and then and when I think of healthcare providers, we also have a multidisciplinary look at the healthcare providers. So we have anesthesiologists, cardiologists, so psychiatry, psychology. So we're really kind of taking a 360 look at each case to really come up with recommendations that kind of encompass the complexity of the problem. So we've released 2 reports since we've been in existence. The last one is actually released earlier this year, and that outlined deaths from 2013 to 2018. And that's the report that I'll be talking with you about the data from. So before we begin, I really always like to start off with what are we talking about when we think about maternal mortality? And there's a lot of sort of information out in the media about what it is and the rising rate both nationally and locally. And so I kind of wanted to put that in perspective so everybody knows exactly what we mean when we say that. So the big umbrella bucket term is pregnancy associated deaths, and those are deaths that occur during pregnancy and up to 1 year after the end of pregnancy, and that's like sort of the big term. And then pregnancy related deaths are deaths that occur during that same time period, but are deemed to be related to the pregnancy itself. And so when we're looking at maternal mortality rates, you hear about the rates are high or whatever, they're looking at these pregnancy related. So those deaths that are determined by committee to be related to the pregnancy per 100,000 live births. And so when we are comparing our numbers to national numbers or other states, we really have to look at the methodology about how someone deems something pregnancy related, like what was that purview that they looked at. And that sometimes can be pretty straightforward, right? So if someone has a hemorrhage and dies from the hemorrhage, like it's pretty straightforward that was related to the pregnancy. But then what about the drug overdose? Like 4 weeks later, and maybe the baby was taken away from DHS, or person had a history of drug use, but was sort of not using that during pregnancy, and then decided to take the drugs that they were using previous to pregnancy, and then overdose because they had less tolerance, right? And so that's where it gets a little bit gray. And so that's the area that we really need to sort of come to some consensus on what's pregnancy related and what's not. And that's why it's so important to have multidisciplinary committees looking at this. So the key findings from our report, you can go to the next slide. This schematic is really looking at all of the deaths, and so each of the colors are a different kind of death. And so you can see here the largest causes are this that navy blue, and then the sort of light green on top of that. Those are like the majority of the cases throughout the last 10 years. And you can see the blue, that navy blue is what we determined to be pregnancy related by committee. And you can see that number is actually pretty stable for the last, since 2011, pretty stable. And that's kind of actually in concordance with national numbers. And so when we talk about our pregnancy related rate being high in the United States, or rising, that's actually an incorrect assumption when you actually look a little bit closely at the data. So the rate is high when you compare it to other countries, but actually but it's not rising like people say. What's actually rising is that gross number, right? So like the pregnancy associated deaths that we're thinking about in this time period. And in Philadelphia, and in other jurisdictions that have published their data, that's really related to the drug overdoses. And those are the ones that have increased that sort of bigger number. And that's why, we think about maternal mortality as rising. It's actually the gross number, that like big bucket term, not necessarily pregnancy related deaths. They're high. And so not to say that we shouldn't address that problem, but they've been steady at a higher rate than when you compare it to other countries. So this is a breakdown of the pregnancy related deaths that we see in the city. So the two highest causes are, number one, cardiovascular conditions, which account for almost half of the cases. And this includes cardiomyopathy and hypertensive disorders. And then the second leading cause is embolisms and things like that. And one place that I wanted to sort of highlight is our hemorrhage related deaths. And so you can see, and this is basically deaths in the last 10 years, we had two that were related to hemorrhage. And when you look at sort of percentage wise, that accounts for 8% of our cases. And that's much less than the national reported average of 10.7%. And when you look more closely at the Philly data, we actually have a religious group in the city that shuns all medical care. And so a number of those cases, so like half of the 8% were related to that religious group. So not to say, it's hard to say whether that person would not have died if they'd received medical care, but it's safe to say that at least it would have been managed a little bit differently than the way it was managed. And so if you sort of excluded those cases, our hemorrhage related deaths are only 4%. And that is actually much less than the national average, as you can see. And that's directly related to a lot of the safety protocols that all of our hospitals have put into place to avert, deaths due to hemorrhage. So this is a breakdown of the racial disparities. So you can see here, there's significant racial disparities that exist in pregnancy-related deaths in the city. Black women account for about 73% of the pregnancy-related deaths. They only account for 43% of the births. And when you look at sort of compared to other ethnicities, you can see that Black people are 3 to 4 times more likely to die. And this is pretty in concordance with national numbers. And there are other disparities that exist. So people over 40 years old and people that are obese are disproportionately likely to die of a pregnancy-related death. And so this is the other sort of big piece of the pie when it comes to pregnancy-associated mortality are the drug-related deaths. So as you can see, looking at 2009 up until 2017, 2018, that it's risen significantly in the last 4 years. And I can tell you that in 19 and 20, this number is pretty stable at a very high rate. And so, when you look at sort of the disparities, and I didn't put that schematic up there, but if you looked at the racial breakdown of drug-related deaths in this time period, Black people and white people are equally likely to die. But so on the surface, it doesn't look like a disparity. It looks like they're both dying at the same rate. However, when you look at sort of the general population of who's dying in Philadelphia around that same age group, white people are actually 2.5 2.5 times more likely to die than Black people in that age group. And so when you look at sort of this like sort of period of pregnancy and a year afterwards, they're equally likely to die. So there's actually a disparity there when you look at that compared to like sort of if they weren't pregnant. And so that's something that is really important to acknowledge and address. And so we've had some other key findings, which I think are really important to focus on here. So if our pregnancy-related deaths, about 72% occurred after delivery, and about 54, more than half occurred after six weeks postpartum. And so as you all may remember in medical school or in your clinical learning, people think that the postpartum period ends 6 weeks after delivery, and sort of all the supports may run out, all the sort of people checking in and things like that may leave after 6 weeks. Even the system sort of like ends then, but really it's important to stress that things don't stop like occurring after 6 weeks. Like there are still sort of like the residuals of maybe pregnancy or sort of what happens after pregnancy that still need to be addressed. Insurance status is important to note here. So 3/4 of our of the deaths had Medicaid, and there's also really important to stress the coexistence of mental health and substance use disorder in our cases. And then also really important to note is that 1/4 of the cases had no prenatal care at all. And that is much less than the Philadelphia average, which is about 8 to 9% of people don't seek prenatal care. So it's certainly disproportionate in this population. And so based on this data and based on discussions of particular cases, we developed a very lengthy set of recommendations. This is sort of the higher level kinds of thoughts and sort of buckets that we put these recommendations in. And I won't read them all for you here, but you can refer to our report to look at all of those in detail, but really sort of highlights around addressing health inequity in healthcare systems, thinking about, really tailoring behavioral and mental health services for this particular population, obviously access to care, preconception, et cetera, directing more attention to the postpartum period. And the rest are listed there, but these are the sort of big priority areas, and there's specific recommendations for each, which I'll go through kind of like what we're sort of prioritizing in the city. So really, I talked about this in the beginning, like how do we fix this issue, right? So, something that comes really clear when we're reviewing the case and going through sort of the details of what happened during pregnancy and afterwards is that it really is that we really need to address these recommendations in a multidisciplinary way. There's not just one person or one organization or one group, one person that can really like address maternal mortality as it stands right now. And so really, we really wanted to sort of bring people together that had agency to change within their organization, and then also like that represented like a lot of the social determinants of health, along with the healthcare system and the other supports that we already have in our city. And so the goal really is to create like a group of people that could come together, work on these issues collaboratively, but then also recognize what the data shows, and that there's a community voice and active participation from their side or from the community side, which can really inform sustainable recommendations. And so what was birthed, and no pun intended, was Birth Justice Philly. And that's is the name for our action team. We call it the OVA, or Organizing Voices for Action. And so these are the sort of groups of people that are at the table here. Like I said, we like really focus on a multidisciplinary group of people. And then also we really focus on like having individuals that had agency to change within those organizations. And so these are some of the recommendations that we're addressing. So you can see here, like a lot of these recommendations need more than one stakeholder to be at the table in order to move forward. And so these are some of the successes that we've been in existence for a year and a half. We started during the pandemic, and these are a bunch of the successes that we've been able to move forward already. And just sort of to think about it in numbers, in our MMR report, we have 33 specific recommendations. Since the report has been published, we've either started or moved along or completed 11 of those 33 recommendations. So 33% of the work is either already completed or ongoing. And so I just leave you with some final thoughts, around, this this work that we do at the health department, recognizing that we really just need to, think about, how healthcare is delivered currently, how it's time to really start engaging other stakeholders to really tackle complex problems. Maternal mortality is not a one stakeholder issue, and it really needs policy change, which Dr. Akrush, I'm sure we'll discuss. It really needs sort of, bringing in, experts in the community that are used to working with at-risk populations, to really come together and really think about this problem from a larger perspective. And so I think the time is now. Clearly there's national recognition of this issue, which is really, really important, because that brings along funding and that brings along innovation. And so, we're really at a precipice of hopefully changing that trajectory for the better. Thank you so much.